state-of-the-art lecture, and what I'm going to talk to you about in this is refractory peptic ulcer disease, and we are going to talk about H. pylori, something that we all pray for. So there's my disclosures again. So how many of you have seen refractory peptic ulcer disease? Just a show of hands. Okay, so most of the room. Okay, good. I don't feel so strange now. So I was really surprised when I did my lit searches for this and started putting this lecture together, just how common this is. I can think in my career, the number of patients I've seen with refractory peptic ulcer disease, and it's not a large number, and I've been practicing for quite a few years. The incidence is estimated to be somewhere between 1 in 100 to 1 in 800 of peptic ulcer disease, but when we think about refractory ulcers, 5 to 10%. At least in the literature. I don't think it's that high in my clinical practice, but I really have to think about that, and maybe I'm missing some of these patients, maybe I'm not scoping them like I should be, and we'll talk about that in a second as well. Now, the definition of a refractory peptic ulcer is an endoscopically proven ulcer, so that implies that you're doing a second look endoscopy, greater than 5 millimeters in diameter, that doesn't heal after 8 to 12 weeks of PPI treatment, and that's standard dose PPI treatment, not necessarily BID treatment. Recurrent peptic ulcer disease, which is often used in the same parlance, but it is different, is endoscopically proven peptic ulcer greater than 5 millimeters that recurs after documented healing, and that's been estimated to be between 5 and 30%. I think it's hard to, and I think one of the reasons we see such a wide range and why it's hard to estimate that latter outcome is that we don't typically do a third endoscopy. Once we document healing, we're done. We kind of say, okay, go on and stay on your PPI if you need to, or call us if you have problems. What are the risk factors for refractory peptic ulcer disease? Well, there's a few, and they all have a lot of overlap. These are not mutually exclusive. The first, and we're going to talk a lot about this, persistent H. pylori infection, but patients may also be taking things that cause ulcers like NSAIDs, either volitionally or perhaps inadvertently, impaired healing, as well as comorbid diseases. Now, one of the reasons we see such a problem with H. pylori is resistance. And this is a somewhat up-to-date pictogram showing resistance rates of clarithromycin, metronidazole, as well as levofloxacin. You can see those range generally in the 20s for clary and metronidazole, up to nearly 40% with levofloxacin. We don't have great data in the US, but more recent data suggests even higher resistance. And this is a condemnation of our practice, and I will make a strong statement here. If you're not testing your patients for eradication after you treat them for H. pylori, you are not practicing correctly. And I would say that looking in the mirror as well. So we need to test our patients. It's in our guidelines. These patients fail therapy too often, so we need to be testing these patients for eradication. Now, there are some caveats with regards to that and some things that we need to absolutely consider. You don't test for eradication until 4 weeks after you've completed therapy, and that's to prevent false positives due to H. pylori shedding, and they should be off PPIs or bismuth for at least 2 weeks. This is data that's not all that old from a US veterans cohort, but I don't think this is unique to the VA, showing about 30% of testing after therapy for post-treatment eradication testing after treatment. So we need to do a better job there. That's one of the reasons why we see these recurrent ulcers and the recurrent complications from these ulcers, because we treat and we forget, and that's not appropriate. Culprit medications and exposures, of course, NSAIDs and aspirin are the most common things that our patients can ingest, but there's other medications, steroids, especially if patients are also taking concomitant NSAIDs. You add in a anticoagulant to the mix, and you've got a nice mixture for a complicated ulcer. Cytotoxic agents, bisphosphonates, olmesartan, and then substance use. We need to be thinking about illicit drugs, especially cocaine, but even tobacco exposure impairs healing and impairs fibrosis. It causes hypoxia and decreases tissue healing. And that's the next topic in terms of why we see refractory ulcers. It's the ulcer characteristics. There's, in some ulcers, an intense inflammatory response. There's scarring, which leads to decreased mucosal blood flow, impairing angiogenesis and tissue repair. That's one of the theories as to why patients get marginal ulcers. That's not a innate, unique peptic ulcer, but the same thing applies to peptic ulcer disease as well. In terms of ulcer size, giant ulcers heal slower. We may need to allow those patients extra time and perhaps delay our second look endoscopy if we are going to document healing, which we should be doing. Average kind of rule of thumb, 3 millimeters per week in terms of healing rate. So if you have a 3 centimeter ulcer or even larger, that may take longer to heal. And they may be more associated with fibrosis as well. Uremia has been shown to be associated with impaired healing, as has COPD, patients who have undergone organ transplantation, who are on immunosuppressants and anti-rejection drugs, and critical illness, and that's kind of an obvious thing. And then the smoking issue as well. Now, I doubt very much that we're going to get our patients to quit smoking because they have a peptic ulcer, but we should tell them that they should do that. What about ineffective acid suppression? Well, probably one of the leading causes is non-adherence to anti-secretory therapy. A lot of individuals, I saw somebody in clinic on Friday who had stopped their PPI, classic GERD symptoms. When they went off PPI, their symptoms came back and they'd go on another PPI and then they'd stop it, and they were told that PPIs are dangerous and harmful, and they stopped it and they were incompletely treated with H2s. We see the same thing in patients or even clinicians who won't prescribe PPIs perhaps, and they treat these with H2s. And H2s have a problem because people develop tolerance to those relatively quickly within about a week or two. So we need to be aware of that. We need to make sure our patients are taking their medicine like we're asking them to take them. There's also a difference with regards to individual PPIs and individual patients with regards to their metabolism. There's slow metabolizers and fast metabolizers. That's governed by the cytochrome P450 system. And then there is a rare group of patients who actually may have acid hypersecretion, classic ZE syndrome, which we've all heard about, not necessarily seen, but we've heard about. The way that you diagnose that is typically with fasting serum gastrin levels, and if you see them off the chart in the 800, 900 range, that's a signal. You need to confirm that with provocation testing. Hyperparathyroidism, primarily the hypercalcemia that occurs as a result of that, can also cause acid hypersecretion, and there's a condition called idiopathic gastric hypersecretion as well that some patients can have. So if you see a patient with a refractory ulcer, these things should be at least coming to the front of your mind. There's also some rare other causes. This looks like a table that's meant to have, it's not, it's just the coloring. So Crohn's, sarcoidosis, lymphoma, eosinophilic diseases, various infectious diseases like TB, syphilis, CMV can also cause refractory peptic ulcer disease. Much less common, but in the right patient, we should be thinking about these conditions. Okay, so this really says exactly what I have said just thus far, so I won't spend a lot of time, but just those three major categories: risk factors, non-compliance, persistent H. pylori, and then non-H. pylori related ulcers. So how do we diagnose these conditions? Well, it's easy. It's an EGD, and we diagnose that typically to document healing, or perhaps in patients where we have diagnosed a peptic ulcer if they have persistent symptoms. And so we should suspect that in patients with persistent symptoms or recurrent dyspepsia if they have additional complications. So if they come in for another bleed. So a lot of this is very intuitive. If they have other signs or symptoms, however, of acid hypersecretion, such as Vernon-Morrison syndrome, diarrhea, hypokalemia, weight loss, thickened gastric folds on our initial endoscopy, we should be thinking about those conditions as well. Now for GU, it's recommended that we do a second look to document healing at 8 to 12 weeks after diagnosing that ulcer, primarily to make sure that it's not a cancer. It can help us identify the underlying etiology. I would encourage all of you, when you do diagnose a gastric ulcer, go ahead and take biopsies for H. pylori. There's no reason not to. Same thing for EOE. When somebody comes in with a food impaction, go ahead and take biopsies for EOE. There's no reason not to do that as well. In the heat of the moment, we're often, I think, hesitant to do that, but it's certainly a very reasonable thing to do. It may be a negative test. They may still have H. pylori. Blood can sometimes affect those results, but if it's positive, then you've got your answer and you can treat them. Biopsies should be done if you find a refractory ulcer, especially if it's refractory, to exclude malignancy as well as other causes. It's recommended that we take 10 to 12 biopsies, not just 3 or 4. They should be 4 quadrant. We're going to take them from the ideally edge of the ulcer, but also if you can and you feel safe, if it looks safe to do that, from even the center. Generally, that's going to be a bit more necrotic. The edge tends to have the more hypermitotic cells if it is a malignancy. If you see nodularity of that ulcer edge, then certainly you want to very aggressively biopsy that. Use jumbo forceps for those biopsies. And then again, think about H. pylori and biopsy for that. Now, relook is not recommended for duodenal ulcers. I've done this a few times in very special circumstances and found some things like lymphoma, and it's very anecdotal. There's not enough data to support relooking for DUs to document their healing. However, if somebody does have persistent symptoms, of course, we're generally going to take another look at those patients. And that's been the context where I have found etiologies that we're not going to get better with PPIs. So reevaluate for risk factors. Interrogate your patient in a nice way. Make sure that they're compliant with their anti-secretory therapy. Make sure that they're not continuing their NSAIDs or their aspirin unless they absolutely have to. Discontinue any other therapies that they may be taking that could impact healing, and then try to mitigate any of those risk factors that are associated with poor ulcer healing. There's not a lot we can do for critical illness, uremia, and other things, but there are some other conditions that we perhaps can mitigate. And then think about getting a fasting serum gastrin, especially if you're not seeing a significant decrease in the size of that ulcer. And then check a calcium as well. Now let's talk about H. pylori. In terms of this context of refractory peptic ulcer disease or even recurrent peptic ulcer disease. These are some of the current recommendations. This is kind of a summary slide that's shown in the middle of this talk, but it is becoming much more of a recommendation from experts in H. pylori to use molecular testing to guide our antibiotic therapy. We'll talk about that in a second. It is in our guidelines, and we really should be, I think, in 2023 in the US, avoiding clarithromycin-based therapy. Unfortunately, we don't. Just like not testing for eradication, we continue to use clary-based triple therapy. There are other therapies that are available, and I'll show you some data on those, and then confirm that eradication. Avoid culprit medications and substances and drug testing. So in terms of anti-secretory therapy for refractory peptic ulcer disease, when you do encounter a refractory ulcer, it's not healing like you think it should. It is appropriate to go ahead and bump the PPI. If you're using once a day PPI, bump that up to twice a day. And then you rescope that person after an additional 8 to 12 weeks of therapy. There's some data, one study that showed a 40 milligram dose of omeprazole produced better healing than H2s, so we should be using PPIs for peptic ulcer disease. More than 90% of refractory ulcers will heal at 8 weeks with BID PPI, and then again recommended to repeat that EGD at 8 to 12 weeks. I put 12 weeks on this slide. If somebody has risk factors, such as having to be on NSAIDs or perhaps they're on anticoagulation and they've had a complicated ulcer and you really want to prevent them from having another complication, and I tend to call the complications bleeding, obstruction, or perforation, then it may be very reasonable to keep them on long-term PPI if that's not contraindicated with regards to their other medications and they're willing to do that. If you do find H. pylori and you eradicate it successfully, you don't need to keep them on chronic PPI because that's the major risk factor. Even if they're taking, continue to take NSAIDs, although in my practice, I probably would continue them on a standard dose PPI indefinitely. And then we'll talk about PCABs, but they do appear to be equally effective as PPIs in terms of this type of therapy. So as we think about H. pylori eradication, there's a couple of things that we really need to keep in mind that should direct our therapeutic approach, and that is optimizing the doses of the medications that we use, as well as the dosing intervals. The duration, we need to be treating these patients for 14 days with these regimens, not 10, not 7. There's good data that shows that 14 is better. We know that compliance is not going to be 100% with patients, and that's one of the reasons why it's probably better is because they've got some intermittent compliance during any regimen. We want to optimize the gastric pH. That means we want to drive it as high as we possibly can during the treatment period in which we're using those antibiotics. And then we want to find therapies or use therapies that are well tolerated by patients that they'll actually adhere to. So when we think about antibiotic stewardship and trying to figure out what regimens to use, it's important that we ask patients what antibiotics they've actually taken in the past. And less than 40% of providers, when they treat H. pylori in this US survey, actually asked patients about prior antibiotic exposure. Have they ever taken any macrolide, not just clarithromycin, but any macrolide. And when we look at the percentage of, or the prescription or the therapies that are being used, standard triple therapy, now this is older data, but I don't think it's changed dramatically. Standard triple therapy is still more than 50% at the time this study was presented and published, more than 50% of the prescriptions for H. pylori. Hopefully it's gotten a little bit better, but again, I'm a little bit of a pessimist with regards to this, but we really should be using quadruple therapy and bismuth-based therapy, as well as some of the other newer therapies that I'll show you. We want to ensure gastric acid suppression that is sustained as long as possible and ensure appropriate dosing of antibiotics in terms of, possibly even weight-based dosing, because there have been differences that have been shown in obese individuals in terms of eradication compared to non-obese individuals. This slide just speaks about antimicrobial susceptibility testing. Has anybody in the audience used this in your practice? That's what I was afraid of. I haven't either. When you hear the mavens like David Graham get up and say, oh, this is easy, it's available, it is becoming increasingly available. Coverage, I think, still may be an issue in terms of getting this, but it is becoming increasingly available, and I do think that this is going to become standard of care within the next couple of years. Our traditional approach to determine antibiotic sensitivity generally in patients who have failed multiple courses of therapy has been biopsy and culture. That's time consuming. It's not always positive, and it's difficult to do. Antimicrobial testing has distinct advantages. You can do this on stool, you can do it on gastric biopsies, and it's a relatively easy thing to do, and there's increasing labs that are doing this across the US. And it gives you the same answers that culture will give you in terms of sensitivities to the antibiotics you see here. In fact, even more, molecular testing or sensitivity testing can tell you whether a H. pylori strain is sensitive to rifabutin, which is the key component to one of the first-line FDA-approved therapies now that's available. This is a statement from David Graham, so I won't say that that's my attribution. He says if you do cultures, you should ask for a refund. So he's really bullish on molecular testing, but other experts in this field also are in terms of this because of its ease as well as its sensitivity and specificity and its helpful nature in terms of directing therapy. I want to spend a little bit of time talking about acid suppression. This is the third link in our H. pylori therapy, but I don't think we often think about why we use PPIs or acid suppression when we treat patients with H. pylori. It's not just to heal the ulcer, it's actually to help the antibiotics work better. So when we really drive up that pH into that 5 to 6 range, if possible, we actually put H. pylori in a more replicative state. And if we have it in a more replicative state, it's more susceptible to antibiotic exposure and killing it. There's also differences with regards to antibiotic clearance. The higher you drive that pH, the longer some of the antibiotics that we use actually stay, their area under the curve increases. And there's growth-dependent aspects with regards to the interaction of antibiotics to the H. pylori with that decrease in acid secretion. So traditionally we use PPIs. We're all very familiar with PPIs, bind to active proton pumps. They have a short plasma half-life. That's why we typically will use them twice a day in our regimens, or perhaps even 3 times a day in some of our regimens. It's unstable in acid, and it's primarily metabolized by the CYP2C19 isoform of the P450 system. We're going to talk a little bit about PCABs. I've already mentioned this. I mentioned this in the abstracts earlier. This is a new class of acid suppressant therapies that are coming. These actually are different than PPIs in that they bind to active and inactive proton pumps. So that's a distinct, we think, pharmacologic advantage. They have a long plasma half-life, and they're stable in acid, and they're metabolized differently than PPIs as well. We haven't seen a ton of clinical difference with regards to PPIs for other acid peptic disorders like GERD and erosive esophagitis, as I showed you. But for H. pylori therapy, there may be some distinct advantages to using PCAB-based regimens. Now, it's also important, I think, to think about our PPIs that we do use. Remember, we have first-generation PPIs, and we also have second-generation PPIs. This is a really pretty classic article that Dave Graham published back in 2018 in Clinical Gastroenterology and Hepatology. This is in vitro data. So this is looking at acid suppression, not in an in vivo or a human model. But what they were able to show basically is the quote unquote potency of the PPIs, with esomeprazole and rabeprazole as second generation PPIs having more potency than the first generation PPIs. Does this make a clinical difference? I think for most of our acid peptic disorders, it doesn't. For H. pylori, it actually might. And we think this might have to do with the way that these drugs are metabolized, as well as some of the dosing that we use with them. And you saw that PCAB all the way actually out at the bottom. If I can go backwards, there we go. Vonoprazan, about twice as potent in terms of acid suppression as rabeprazole, which was slightly more than Nexium or esomeprazole. So it'll be interesting to see how these PCABs actually influence our therapy for H. pylori. We do have now a PCAB-based therapy that's been FDA approved, and that is a vonoprazan-based therapy. This is data from the phase 3 study of these two regimens that include vonoprazan. And this is basically a study that compared a dual treatment, which was vonoprazan and high-dose amoxicillin, a triple treatment, which was clarithromycin, amoxicillin, and vonoprazan, to traditional lansoprazole, clarithromycin, and amoxicillin therapy. Non-inferiority study, you can criticize non-inferiority studies for possibly being able to game them a bit, and that's a legitimate criticism for many non-inferiority studies. And what this study showed is that, in fact, these were non-inferior, relatively decent, I wouldn't say high, but decent healing rates. Triple therapy with vonoprazan was non-inferior to lansoprazole triple, and actually was superior to lansoprazole triple. The dual therapy of vonoprazan was basically non-inferior, not any better, but not any worse. And that was in the modified intention to treat, as well as the per protocol. The important thing, I think, to take away from this, when you look at that red bar in the per protocol, we got over that 90% eradication rate. And that's really the goal. If we wanted to have a quality indicator for eradication of H. pylori, it should be 90% eradication with the regimens that we use. That's the stated goal in many review articles and guidelines. There's also a new rifabutin-based therapy. This is why I mentioned this when I talked about sensitivity testing. This is not really new data anymore. This also is from David Graham. This is an FDA-approved regimen of rifabutin, amoxicillin, and omeprazole. This comes as a combination pill. Patients have to take 4 pills 3 times a day. And in this study, they compared it to amoxicillin and omeprazole. This is high-dose amoxicillin. And in the patients with confirmed eradication, they got over that 90% eradication rate with this rifabutin. There's almost no resistance to rifabutin that H. pylori has, and the resistance rates to amoxicillin are about 5 to 6%, so very low compared to the other antibiotics we use. So other options besides our traditional triple therapy for us to use that are either here or are coming soon to our H. pylori armamentarium. In terms of complications from recurrent peptic ulcer disease, one of them is bleeding. I just threw this in there because I thought this was a kind of an interesting article from 2018. And this has actually changed the way I practice. So if I have somebody with I diagnosed with an ulcer, let's say they have a complicated ulcer, they bleed, we inject it, we clip it, maybe we burn it, they go away, but then they come back 2 weeks later and they're bleeding again, they're in the ER, their hemoglobin's 5, they're hypotensive, we resuscitate them. I'm gonna go back in and I'm gonna have a over the scope clip ready to go. And that's what this study showed. This is actually a study looking at recurrent ulcer bleeding and the endoscopic approach to these patients. So this is complicated recurrent ulcer bleeding or refractory ulcer bleeding, either one. And what they were able to show was that using over the scope clips was significantly better than our quote unquote traditional endoscopic methods with the through the scope clips, as well as injection of sclerosants and epi and heat therapy. So do keep that in mind if you're not familiar or haven't used the over the scope clips. I encourage you to get familiar with that. This is not a huge subset of patients, but the differences were relatively dramatic. I think it's again, has to be placed in context in terms of what you find and what the ulcer characteristics are. But I think that we probably need to be using these types of devices more aggressively in these types of patients. So finally, surgical management. Not a lot to say. This is kind of like a slide on surgery for chronic constipation. When you have to, you have to. You really don't want to if you don't have to. This is reserved for peptic ulcer disease that fails to heal after twice daily PPIs for 24 weeks. And after you've corrected other factors or addressed them. There's a variety of different surgeries that can be done, but there is no good data to really inform us of which surgeries should be done, when surgery should be done, and how it compares to continued medical therapy. So I think we tend to drag this out as long as we can, but in some patients this may actually be necessary. So it is important to be in close contact and consult with your surgeons. So with that, I'm just get to my summary and recommendations. Refractory peptic ulcer disease, remember, is defined as non-healing ulcers after 12 weeks of PPIs, and that's standard dose PPIs, generally once daily. Sometimes many of us will use twice a day for a couple weeks and then decrease patients down to once a day. I think it depends on whether they come in with a complicated ulcer or not. Biopsies of the ulcer, as well as the antrum and body for H. pylori, are useful and should be done. Even in the heat of the moment, if you feel safe doing that. If you do find that patient does have H. pylori, then of course you want to treat those patients. If you do have access to molecular testing, we're going to find we'll be able to tell in the next few years whether that's an a priori first line thing that we ought to be doing, or is that reserved for these refractory ulcers. Do not use triple therapy anymore for your H. pylori. Do test for eradication after you complete therapy. We do have now PCAB-based therapies that are going to be available. They are FDA approved. They're not being marketed just yet. And then the rifabutin-based therapy, which is marketed and is approved for initial therapy of H. pylori. And again, I highlight that verify eradication. Consider alternative endoscopic approaches in those patients who have recurrent complications, meaning the over-the-scope clip. And then when you do encounter these refractory ulcers, go ahead and bump the PPI up to twice a day. Do that for an additional 8 to 12 weeks and then re-scope them. We'll see how the PCABs work for these types of scenarios, and then finally consider that surgery for somebody who doesn't heal within over 24 weeks. So thank you very much. Appreciate it.